This conference will now be recorded.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بكم جميعا في المحاضرة الأولى من سلسلة محاضرات التي تقدمها الرابطة الطبية الفلسطينية الأمريكية PAMA في كيفية التعامل مع جهاز التنفس الاصطناعي لمرضى الكوفيد 19. اسمي الدكتور يوسف خلفة، أخصائي أمراض سرطان ودم والرئيس الحالي للجمعية. لا شك أن الكورونا ضربت العالم وفلسطين خاصة، ومنذ بداية الجائحة الرابطة الطبية الفلسطينية الأمريكية كرست جميع إمكانياتها الخدماتية والصحية والتعليمية والمالية لخدمة القطاع الصحي في فلسطين، وذلك من خلال إرسال مستلزمات طبية وتقديم سلسلة من المحاضرات. كون أن الهدف والميشن من الجمعية هو تحسين الوضع الصحي في فلسطين. هذه ستكون المحاضرة الأولى من سلسلة 5 محاضرات. على اليمين الشاشة هناك نافذة ويندو إلى الشات أو دردشة. بعثت رابط من أجل تسجيل لهذه المحاضرة لمن لم يسجل، فالرجاء من الجميع التسجيل، والرجاء ممن يحضرون المحاضرة كتابة الاسم الطبيب أو الطبيبة الأول والأخير من أجل الحصول إن شاء الله على شهادة حضور. سنقوم في نهاية المحاضرات ال5 بإرسال أسئلة لكم، ونرجو منكم الإجابة عليها وإرسالها لنا من أجل أن نستطيع تزويدكم بشهادة حضور المحاضرة. بعض الأمور المهمة، الرجاء من الجميع وضع المايك والصورة على الميوت والهايد خلال المحاضرة. فقط المحاضر سوف يقوم بالتحدث. الرجاء تأجيل الأسئلة إلى نهاية المحاضرة، لعل الدكتور محمود يجيب عليها من خلال المحاضرة، فلا داعي لذكرها إذن، وكتابتها في نهاية المحاضرة وسيقوم بالإجابة على الأسئلة. من دون أي تأخير دعوني أعرف الدكتور والأخ والزميل محمود أمارنا. هو من بلدة يعبد جنين، تخرج من جامعة القدس أبو ديس، حصل على شهادة البكالوريوس في الطب، ثم انتقل إلى الولايات المتحدة الأمريكية وحصل على التخصص في أمراض الباطنية، ومن ثم التخصص في الأمراض الصدرية والعناية الحديثة. هو أخصائي في مستشفى جونسون ميموريال في تينيسي، وهو أيضا أستاذ مساعد في كلية إدوارد فيا في تينيسي أيضا. الدكتور محمود أمارنا، تفضل، وشكرا جزيلا لك وللجميع على الحضور.
مشكور أخ يوسف، جزاك الله خير، وشكر موصول طبعا لباما, the organizers of this lecture series about mechanical ventilation في هذا الوقت غير المسبوق اللي يتعرض فيه النظام الصحي في العالم وفي فلسطين وغيرها من البلاد لضائقة، يعني لا شك إنها شديدة جدا، وكان لابد من إنه يعني to share knowledge. يعني ال medical teams all over the world are contacting and communicating with each other to share knowledge and experiences، لأنه حقيقة في كثير من الأمور يعني ما فيها clear guidelines up to this point of time. The main purpose of this crash course on mechanical ventilation is to share knowledge about the basics of mechanical ventilation and do some correlations when it comes to COVID-19 based on the most recent evidence that we learned from the Chinese, European, and USA data. فبسم الله نبلش في المحاضرة. Mechanical ventilation. I have no conflict of interest. ما في أي علاقة مع شركات الأدوية بالنسبة لموضوع هذه المحاضرة. The main objective of this lecture is to provide you guys with a brief a review of different common modes of mechanical ventilation, then be more focused on the assist control mode of mechanical ventilation, which is the most common mode, and then to learn how to initiate and change the settings on mechanical ventilation after intubation. Provide you with some highlights on vent management for COVID-19 patients, and brief on weaning from the vent. Mechanical ventilation is essentially a non-physiologic way of breathing. The physiologic way of breathing happens by creating a negative pressure in the pleural space, and then the air will be sucked in to the major airways. Then the lung will be expanding, the air will come into the lungs, gas exchange happens. In mechanical ventilation, we push the air into the airways, which is a non-physiologic، يعني طريقة غير طبيعية في تزويد الجسم بالأكسجين والتخلص من ثاني أكسيد الكربون. Modes of mechanical ventilation, all of them serve the same purpose, which is to support adequate ventilation and oxygenation. Ventilation and oxygenation are the main functions for the respiratory system, but each mode of mechanical ventilation has its particular style and mechanism of action. We have two main types of mechanical ventilation, one of them called volume limited, and the other main type is pressure limited. The volume limited mechanical ventilation, the gas flows to the patient until a preset volume is delivered to the ventilator circuit. The airway pressure as a result varies with the volume delivered, the compliance of the airways, and the airway resistance. Volume limited mechanical ventilation is the most common type of adult ventilation. The advantages of this mode of ventilation that it would provide us with stable minute ventilation with non-tidal volume. But the disadvantage that this tidal volume, which is fixed, can be in expense of peak airway pressure, which can go high, which can go up with a fixed tidal volume, and that's based on, again, the compliance and the airway resistance. Pressure limited mechanical ventilation, gas is allowed to flow into the lungs, reaching preset airway pressure limit for a predetermined inspiratory time at which a valve opens, allowing exhalation to start. So we fix the airway pressure, and as a result, we have variation in the volume delivered by the ventilator, and that change depends mainly on the airway resistance, lung compliance, and the integrity of the ventilatory circuit. We have like different modes, but the common modes we use in our ICUs. Number one, volume limited assist control, then the pressure regulated volume control, the PRVC. We have also the pressure limited assist control, then the intermittent mandatory ventilation, or the synchronized intermittent mandatory ventilation with pressure support. We also have the pressure support mode of ventilation and the CPAP. For the sake of this presentation, which is going to be for 1 hour, we are going to focus our attention to volume limited assist control with the SIMV, pressure support, and CPAP, pressure limited assist control, and the other modes of ventilation like the APRV will be left for the other physicians and the other lecturers to take care of, inshallah. The volume control mode. The volume control mode, you have like a preset number of breaths per minute and preset volume. So the machine will be in charge and will be in 100% control. At the same time, the patient has no autonomy. The patient will be losing his autonomy, and he has no, he's not allowed to breathe over the ventilator. And as you can tell from that, it's uncomfortable way of ventilation, and it's largely restricted to patients who are apneic, deeply sedated, or they are apneic as a result of brain damage, or in the cases of muscle paralysis. So as you see here in this diagram, you see all breaths are supported by the machine and the patient has no autonomy. You can tell that by the absence of the negative deflections. The normal way, or like in the assist control, not the volume control, not the control, the assist control, you see some negative deflections indicating that the patient is trying to make an effort, and then the machine stands up and provides the patient with the full support with the preset tidal volume. But in this mode, the patient cannot make any extra breaths on his own. Now, the assist control mode. So we talked first about the control mode. Now we have the assist control mode. The ventilator always delivers a full positive pressure preset breath. So in other words, we have a minimum minute ventilation. In the machine, you dial the tidal volume and you fix it, say, at 500 cc's. You have a respiratory rate, say, at 16. And if the patient has ability or wants to take an extra breath, the machine will allow him to do that. And that breath will be fully supported with the full tidal volume preset by the physician. So you see here, this is the pressure wave for a patient on the assist control mode. You see the negative deflection. That means, the patient tries to initiate the breath, so he creates a negative pressure in the circuit. The machine is smart enough to sense that negative pressure, and then when that happens, based on the sensitivity of the machine, most of the time we set the trigger sensitivity based on flow or based on pressure. The pressure sensitivity usually -1 to -2 or -3 centimeter water, or sometimes we do it based on the flow. We do like a flow of 2 liters per minute. So when the machine senses that much of flow or that much of negative pressure, the machine will fully support the patient with this extra volume, and this volume will be equivalent to the volume that you set initially on the machine. So this is the assist control mode. The advantage of this, that the patient is able to control his own minute ventilation. We know based on physiology that the minute ventilation is mainly controlled by the respiratory center in the brain stem based on the level of the PCO2. And then if the patient needs to breathe more based on the homeostasis and the H+ level and the PCO2 level, the patient can adjust and breathe over the sit rate, and this this will be supported 100% with the full tidal volume by the machine. This is a very good mode to start with when the patient gets intubated, because it's a resting mode. The patient is not allowed to breathe on his own. He will be supported for each effort he wants to do on top of the ventilator, and that way we can conserve energy and work of breathing and divert the blood from the respiratory system to more vital organs like the heart, the kidneys, and the brain, which is essential in sick patients when they first get intubated. So it's a very good setting to start with after we intubate our patients, our sick patients. We have another form of volume limited ventilation, which is called the pressure regulated volume control, the PRVC mode. We have essentially a smart RT, respiratory therapist, inside the machine. In other words, we have an algorithm that will be utilizing both volume limit with pressure limit. So it's a form of volume control ventilation where tidal volume is set and the applied airway pressure changes to attain the target tidal volume. Based on this, the inspiratory flow is variable and changes with patient effort and lung mechanics. And it's more comfortable to the patient because it can adapt to the compliance and the mechanics, and the patient can synchronize and cooperate with the machine more than other modes of ventilation. Just as an example, this is a patient cruising on the PRVC here. Something happened here and there was a drop in the compliance. For some reason, patient gained some fluids the patient has pneumothorax, whatever, the compliance went down. As a result, when the compliance went down, the lung is not able to expand for a given change in pressure. So as a result of this, as you see here, the tidal volume goes down. So to compensate for that, the machine is smart enough to sense that decrease in volume, and then the pressure will go up. And when the pressure goes up, to compensate for the less compliance, this tidal volume will return back to the preset value on the machine. The SIMV, synchronized intermittent mandatory ventilation, that's another mode of volume control or volume limited ventilation. The patient receives periodic positive pressure breaths from the ventilator at a preset volume and rate, and that will be synchronized with patient's effort. So that's more comfort that the patient, the machine will provide the support at the time of, the breath initiation by the patient. The patient can also breathe spontaneously above the sit rate on the ventilator. Now, the extra breaths, if the patient wants to take an extra breath, the tidal volume of that breath will be completely dependent on patient's effort. So you see here, this is the assist control. We said in the assist control volume limited mode of ventilation, we have control breaths where the machine provide the full tidal volume based on the numbers we have. And then if the patient wants to take an extra breath, this is the assist breath here. Patient created a negative pressure, the machine senses that negative pressure and then will fully supported by the full tidal volume. This is the assist control mode. In comparison, the SIMV, this is like the sit rate. We have like a tidal volume, say, of 500. The machine will give the 500 tidal volume. But if the patient wants to take an extra breath, this extra breath will depend mainly on patient's effort. So there is a mix of physiologic and non-physiologic breaths. So there is a mixture of positive pressure ventilation and negative pressure breath. So we have, in theory, less iatrogenic effects in the form of barotrauma or biotrauma, and also less hyperventilation. The machine will not support 100% with the full tidal volume, so the effect of hyperventilation will be much less than the assist control mode. The spontaneous breaths are more physiologic than with negative pressure breaths, which gives some opportunity for the respiratory muscles to train, so less effect on the weakness of muscles as a result of mechanical ventilation. So again, this is a repetition. This is the spontaneous breath on the SIMV, and this is the breath provided by the machine, and it's synchronized with the spontaneous breath, which is also nice to have and more physiologic, more convenient to patients. Let's move to another mode of ventilation, which is called the pressure support ventilation. Pressure support augments patient's own spontaneous inspiratory effort. The pressure is maintained at a preset level until patient's inspiratory flow falls to a certain level, which is most of the time 25% of the peak flow rate. And it's considered to be one of the weaning modes, and many times we see it combined with the SIMV. Patients has control over the rate, the inspiratory time, and the inspiratory flow rate. The tidal volume is determined by the level of the pressure support. So the higher the pressure support, the more or the bigger the tidal volume is, and the patient's effort, strength, and also on the pulmonary mechanics. Say the patient's lungs are very stiff, the extra breath will be, very small in tidal volume. When the compliance improves, you see that the tidal volume started to improve on the same pressure support level. Or you might need to dial up the pressure support to compensate for the bad lung mechanics. So look here, this is SIMV, Synchronized Intermittent Mandatory Ventilation, utilizing pressure support. So look at the picture here. We have the SIMV. This is the breath supported by the machine. Those are the spontaneous breaths, physiologic, positive and negative pressure. But the amount of change is less. When we have the pressure support, the patient's effort will be augmented in the spontaneous breath, and the tidal volume will improve as a result of this intervention. So many times we have the SIMV supported by pressure support to augment patients' spontaneous breath or the extra breath. CPAP, continuous positive airway pressure. It's a mode that allows a patient to breathe spontaneously at a normal or an elevated positive pressure baseline. So look here, this picture, we have the CPAP on room air. I'm sorry, this patient who's breathing on room air. And we have here a CPAP of maybe 10 centimeter water. You have spontaneous breath, but at a higher pressure level above the atmospheric pressure. Now, we know with the CPAP that the patient does all the work of breathing, and the machine will not be supporting him with the pressure support or with a rate. The advantage of the CPAP that it helps recruit the alveoli. In other words, help open up the alveoli to participate more with oxygenation and ventilation. The CPAP also helps restore and maintain the functional residual capacity of the intubated patient who can breathe spontaneously. And for sure, we use the CPAP as a weaning mode to help liberate and wean the patients off life support or the mechanical ventilation. The PEEP or the positive end expiratory pressure, it's again similar to the CPAP, a level of positive pressure that is maintained within the airways at the end of expiration to prevent alveolar collapse and to recruit non-functioning lung tissue. And we apply the CPAP with all modes of ventilation to help improve the oxygenation. So the PEEP help improve and increase the functional residual capacity, help improve the alveolar recruitment, improves the VQ matching, and it helps also to redistribute the extravascular lung water. And all of these work together to help improve the oxygenation. But at the same time, PEEP has potential side effects. If we apply more PEEP than needed, that leads to over-distension of the alveoli, which leads to biotrauma. In other words, over-distension leads to the release of inflammatory markers, a redox reaction, and that contributes to the acute lung injury pathophysiology, and also can lead to barotrauma, complications like pneumomediastinum, pneumothorax, and tension pneumothorax potentially. Also, the PEEP can lead to decrease in cardiac output by reducing the venous return to the heart. And it can increase the intrapulmonary shunting by over-distension of the non-diseased areas and lead to decreased blood flow to these areas and shunt the blood to the diseased or to the pathologic areas. Look at those pictures here. This is an alveolus without PEEP. The PEEP helps open up the alveolus, and that's the meaning of recruitment. If this alveolus is filled with inflammatory fluid or water or blood, or you name it, you use PEEP, and this PEEP helps open the alveolus, so part of that alveolus will contribute to the oxygenation and the gas exchange. If you overdo the PEEP, the alveolus may burst out, and then you get into trouble, and you get into the situation of barotrauma. So the effect of PEEP, you need to use it smartly. You need to balance the benefits with the potential risks. From the oxygen delivery equation, we know that oxygen delivery to tissues depend on cardiac index or cardiac output to the body surface area multiplied by oxygen content in the blood. So PEEP improves the oxygen content, but in the other hand, decreases the cardiac index. So if the patient has a poor cardiovascular reserve with low ejection fraction or low cardiac function, when you apply high PEEP, you are risking less oxygen delivery to the tissues by the bad effect of PEEP on the heart. So you need to be vigilant of those side effects of PEEP. Now let's move to the initial ventilator settings after intubation. I'm sure all of you guys are familiar with indications for intubation and mechanical ventilation. Essentially, the patient is losing one or two of the main two functions of the respiratory systems, the oxygenation function or the ventilation, or both together, to where the patient is unstable and requires stability by providing support through the breathing machine. After we decide this patient needs to be intubated, we go ahead and intubate him. And then the question is, what mode of ventilation? How much of oxygen we need to give him? How much of PEEP? How much of tidal volume and the citrate we need to provide through the machine? That's assuming we are starting on the volume limited mode of ventilation, which is the most common mode to start with after we intubate patients. And from now on, again, our focus is on the volume limited assist control mode of ventilation. So I suggest that the initial ventilator settings, that we start with the volume limited assist control, or the PRVC. That's the mode of ventilator that I would suggest to use after intubation. The amount of oxygen we need to give, I would suggest to start with 100%. The reason why, number one, the pathology for which the patient was intubated can progress. So start with 100%. Also, when you intubate the patient, you might get in trouble because of main stem intubation or pneumothorax or aspiration or whatever. A lot of things can happen. So it's safer to start with 100%. Then the PEEP, start with 5 to 10 centimeter water. Tidal volume, it depends on the pathology. So if your patient has a pathology like ARDS, the recommendation is to start with a tidal volume between 4 to 8 ml per kg, ideal body weight. While if the patient has a pathology or different pathology like COPD, non-ARDS, the recommendation is to do a tidal volume of 6 to 8 ml per kg. The citrate, good start around maybe 12 to 16 for non-ARDS. For ARDS patients, you start maybe 12 to 16, but you can give more because essentially you are using less volumes, and you can go up on the respiratory rate up to 35 breaths per minute. Once you set up the tidal volume, it's always good habit to check on the plateau pressure. The way how we check the plateau pressure is by talk to your respiratory therapist, and you have a button called inspiratory hold. So you push on that inspiratory hold for about 30 seconds, and you read the plateau pressure. You can see it on the ventilator screen. And the recommendation is to have this plateau pressure less than 30 centimeter water. In 30 minutes after intubation, we obtain the portable chest X-ray and the ABG. The portable X-ray is essential, to look at the pathology in the lung, progression of the underlying problem, and also to look for iatrogenic problems. In other words, problems that you as a physician cause to the patient. Number one, rule out right main stem intubation, rule out pneumothorax, and many times we do a feeding tube. This feeding tube may get displaced and inserted in the lung instead of going to the stomach. You look at your central line, make sure it's also good and can be used and in good placement and was not complicated by pneumothorax or hemothorax or you name it. So getting the chest X-ray is helpful to make sure we don't have other issues and to follow up on the underlying pathology. The first ABG helps you see if you need to make any changes. And as we know, looking at the ABG, we have the PO2 part and the saturation, which can help you titrate the FiO2 and the PEEP. So the PEEP and the FiO2 both, the changes in these two things on the ventilator will be reflected on the change on the PO2 and the saturation. While the changes in tidal volume and the sit rate will be reflected on the PCO2 and the pH. So the PCO2 and the pH values depend on the tidal volume and the sit rate, in other words, the minute ventilation. And then, like when you do the, like you might ask, like how we can make the changes on the FiO2 and the PEEP. We have a table suggested by the ARDS network. We see like for different FiO2s, we have a recommendation of how much PEEP we can give to that patient. For example, if you have a patient with a PEEP, or of like FiO2 of 100% and a PEEP of 10, and you do the ABG, and then the ABG shows that the PO2 is still in the 40s, you have space in the FiO2 in the PEEP, and you can go higher on the PEEP to support better oxygenation and provide with the recruitment. Now, if you do an ABG and your pH shows respiratory acidosis, more PCO2, and low pH, you can go higher on the tidal volume. In ARDS situation, you can go higher to a tidal volume of, you can go higher on the respiratory rate up to 35 breaths per minute. You can also go up on the tidal volume up to 8 ml per kg, keeping in mind that you need to maintain the plateau pressure less than 30 centimeter water. So yeah, you use the first ABG to make the changes, and you try to get your FiO2 below 60%, and the sooner the better, as tolerated and allowed by patients' pathophysiology and compliance and those kind of things. And the reason why you are trying to limit the effect of oxygen toxicity in the lung. The higher oxygen you give the patient for more than 24 hours, the higher the chance that oxygen starts to rev up the redox reaction and contribute to the pathology and lead to more issues and problems with the oxygenation and the ventilation. Now, let's switch gears and talk a little bit about ARDS definition. Here we have the Berlin definition of acute respiratory distress syndrome. They have like a timing requirement that we have an inciting or accident or a known factor which has happened within a week of worsening respiratory symptoms. The chest X-ray suggestive of bilateral obesities, and those changes in the X-ray not fully explained by effusions, collapse, or nodules. The origin of edema should not be coming from cardiogenic causes. We can do that simply by doing BNP or by obtaining an echocardiogram. Make sure that the edema is not fully or the infiltrates are not fully explained by cardiac compensation. And we have different severity ranges, like the severe ARDS, where you have the PaO2 to FiO2 ratio less than 100, the moderate between 100 and 200, and the mild between 200 and 300. There is like a nice table. I got this from UpToDate. I'm sure all of you guys have access to UpToDate. And it does show like the ARDS vent management. So again, we set up the tidal volume between 4 to 8 ml per kg based on the ideal body weight. And here I want you guys to memorize the equation for ideal body weight in inches and in centimeter. Here we are familiar with the inches and the feet. In فلسطين طبعا النظام المتري هو السائد، فبتستخدموا second equation for males and for females. So we calculate the ideal body weight and we multiply the body weight by the 6 ml per kg, or sometimes you might need to start with 8 ml per kg, and then you start to step down based on the plateau pressure. If your plateau pressure, say you start with 8 ml per kg, you check the plateau pressure and it's 40. You come down to a tidal volume of 7 ml per kg, and you check your plateau pressure. If it's still high, you step down to 6 till you bring it to less than 30 centimeter water, and you can step down on the tidal volume down to 4 ml per kg. Then again, you change the oxygenation, the FiO2 and the PEEP based on this table. So you have a range of PEEP for each given FiO2. All right, so حاليا بدنا نحكي عن الأمور relevant to mechanical ventilation on COVID-19 patients. السؤال الأول, or the first question, is what is the indication for intubation in COVID-19 patients? يعني COVID-19 is like any other pathology, would lead to ARDS. The virus pathophysiology that it would attach to ACE2 receptors, and we have a lot of that in the lung tissue, and when it gets down deep, can lead to a lot of inflammation, hyaline membrane, and diffuse alveolar damage, and that would be reflected on what we call ARDS. Now, for other patients with ARDS, very obvious, we go ahead and intubate when the patient becomes hypoxemic and he filled the low flow oxygen, then the medium flow, then the non-rebreather, then the high flow, then the non-invasive way of ventilation, but for COVID-19, because of that risk of spreading the infection to team members, there was some ideas about doing early intubation, because if you go to the high flow, or to the non-invasive ventilation with the BiPAP, you are running the risk of spreading the virus to team members. So some hospitals and physicians started to adopt the early intubation, and that's the time after they feel the medium flow or the non-rebreather or the high, or even before you get to the high flow. Some people straight they go ahead and intubate, but that has a lot of potential side effects if you adopt the early intubation policy, that you run out of resources early on. That's number one. Number two, for COVID-19 patients, we know that most of the patients stay at least a week to 2 weeks, even sometimes longer than 2 weeks on mechanical ventilation. If you adopt the early intubation, again, you exhaust resources early. And the other issue with that you can increase the risk of ventilator-related lung injury and ventilator-related infections, and laying on the bed sedated increase the risk of developing blood clots and bleeding, stress ulcers, and you name it. So now the trend after some data that you try your best to delay the intubation if it's allowed by patients' hemodynamics and distress. If there is no evidence of distress, you can step up to high flow as long as your flow rate less than 35 liters per minute. You can utilize non-invasive way of ventilation like the BPAP or the BiPAP. As long as you have negative pressure rooms, you can still utilize it, especially for patients with COPD, knowing that there is a higher risk of spreading the virus to the team members or to patients. So when you consider the high flow or the BiPAP, try your best to put your patient in a negative pressure room and be more serious with protective measures with masks and the PPEs and all of these precautions. So that's like the thing about intubation. But generally speaking, if you see that your patient in respiratory distress, if you see a big change in patient's oxygen requirements within a few hours, that he jumped from 4 or 5 liters to maybe 15 or non-rebreather, that you know that he's going to get worse, and it's better to go ahead and intubate him. If the patient has hemodynamic instability, also a very clear indication for intubation along with hypoxemia. Now, when you do the intubation, you need to take all of those precautions. Number one, put your patient in a negative pressure room, use protective equipment for yourself. Try to limit the number of people in the room, doing the intubation part. Number three, try to limit aerosol producing interventions like ambu bagging. Try to limit ambu bagging to the best of your ability. The way how I do it in my ICU, I try my best to oxygenate the patient very well when he can breathe spontaneously before intubation. Give him the non-rebreather. Sometimes I put a nasal cannula, in addition to the 100% non-rebreather, and provide the patient with oxygen to keep his oxygen at the highest possible before you do the rapid sequence intubation. And then you do the sedation with muscle paralysis to limit a patient's ability to cough and spread the infection. And you limit or try not to do the ambu bagging. And if you need to do the ambu bag, make sure that you have the filter attached to the mask and the bag. So when you do that, do it quickly and use the best one in-house for the intubation task. Don't do any trials, just be quick and get done with it. If you have a video-assisted laryngoscope tool, it's better to use it because it gives you more space and gives you a better view. You can see with it. It's better than the direct laryngoscopy, because with the direct laryngoscopy, you have to lean forward closer to the patient, which is not good. Some people might use what's called the intubation box, which is like a transparent box with access by 2 holes where you can, insert your hands and do the intubation. So that's the intubation part. Try to avoid doing the bronchoscopy unless it's absolutely indicated, like patient hemoptysis or a central lesion that needs to be extracted, or a foreign body, or something else is going on. You have to have a good indication, because again, it's aerosol producing intervention. So that's the thing about intubating your patient. And before intubation, while the patient is progressing in severity, you need to have frequent, evaluations for intubation. Okay, so ARDS management with COVID-19, we adopt, or the guidelines recommend that we be conservative with fluid management. Don't give the sepsis bolus protocol with IV fluid if at all possible, because most of the time patients don't have the bacterial infection. It's most of the time the virus and bacterial infections can happen in about maybe 10 to 20%, and most of the time it happens late in the course of infection. Early on, it's the virus. Utilizing prone ventilation. Prone ventilation is not a new mode of ventilation. It's a technique that we use to help improve the VQ mismatch by flipping the patient upside down and try to utilize other areas in the anterior part of the lungs to contribute to oxygenation and have a better match when we put the patient's anterior aspect in the dependent position by putting them in the prone position. So it's a technique which is very helpful. 3 days or 4 days ago, I intubated a patient, COVID-19, who was 100% and PEEP of 20, barely sitting in like the upper 80s. After proning, patient's oxygenation improved a lot. Like we went down to FI2 of 60% and PEEP of 16 within maybe half an hour. So it's very efficient. The indication for prone ventilation, number one, that you have enough resources to do it. Very important. You have to have a team member who's familiar with proning. Otherwise, if people don't know how to do it, can be catastrophic, because you might lose the continuity of circuit. Connection to the ventilator, which is by itself a bad thing to happen. The virus will be spreading around, and you are risking the team members. That's number one. Number two, you might lose your lines, central line, feeding tube, Foley catheters, all of that stuff. So you need to have good number of people who are familiar with the technique, or at least familiarize themselves with the technique. It's good to do the proning or flipping from a prone to supine position at the time of shift change, like when the nurse team shift change, we have more personnel, more people who can help do the proning. So this might help. By numbers, the indication for prone ventilation, if you have the patient PaO2 to FiO2 ratio of less than 150 to 120, and your FiO2 more than 60%, and PEEP more than 10 to 15, that's like a good indication to do it. We do it for about 12 to 16 hours, and then we flip the patients to the supine position, and then we keep changing positions, supine, prone. The time we stop is the time when we have FiO2 less than 60%, PEEP less than 10, and the ratio started to improve and it's more than 150. But again, it's helpful. Can improve outcomes, but at the same time you need to do it smartly, and you need to educate the team about how to do it. Neuromuscular blockade, extrapolation from ARDS management for other pathologies using the cistracorium early on, first 48 hours, was found to be helpful in some of the studies. So it's a tool that you can use to help oxygenate the patients, and also it can help with patient ventilator asynchrony. If the patient is uncomfortable, he cannot sync with the machine, especially with low tidal volumes. You give the muscle paralysis and it knocks the patient down, can help smooth the process of mechanical ventilation. Using steroids in general, that's only talking about ARDS regardless. You can use steroids 1 milligram of prednisone per kg, but early on in the pathology, unless you have like a contraindication, and might improve outcomes. Late use of steroids after 14 days, it's not going to help, and it might contribute to problems. Now, using steroid in COVID-19, early or maybe few months ago, before we had the data from the recovery study, which showed benefit from the dexamethasone, there was a conflict like between the different societies, WHO, CDC, and the Society of Critical Care Medicine. Some people adopted steroid, others were against steroid altogether. But now we have decent evidence that using dexamethasone or the equivalent, but I would say dexamethasone, if you have it, use it. 6 milligram per day for 10 days or till discharge is something that you can utilize. Some people might use higher doses of dexamethasone, especially for patients with ARDS, moderate or severe, using 20 of dexamethasone IV for 5 days, followed by 10 IV for 5 more days. You know, they use higher doses. I'm not sure if there is enough evidence to support that, but you know, some of the practices and societies recommending that much of steroid to be given to COVID-19 sick patients on mechanical ventilation. But generally speaking, even for the patients who are not on mechanical ventilation, who are on supplemental oxygen, they can utilize the dexamethasone at 6 milligram QD for 10 days. Recruitment maneuvers, you know, different maneuvers we can use, but the one that you can utilize, which I would recommend using maybe PEEP or high PEEPs, like between 35 to 40, applied for maybe 30 seconds to recruit the alveoli. This might help with oxygenation, but you need also to look at your hemodynamics and the risk of barotrauma. If you have thin lungs secondary to COPD, doing recruitment sometimes can be catastrophic and lead to pneumothorax. So be selective. I don't use recruitment maneuvers as much. I depend more on the proning neuromuscular blockade if needed. The APRV mode of mechanical ventilation is the airway pressure release ventilation, can improve oxygenation and can be one of the rescue things that you can do for refractory hypoxemia. I will leave that topic to Dr. Majdi Hamarchi will be talking about this mode of ventilation. Same for pulmonary vasodilators. You can use them, but pulmonary vasodilators can improve oxygenation. But there is no proven mortality benefit for ARDS related to other pathologies. For COVID-19, we don't have enough data. If you use pulmonary vasodilators, if you have that option, you need also to be vigilant of the you know, circuit problems and possible you know, dispersion of the virus through, because many times you give it through the you know, inhalation part through the circuit. And it has some issues sometimes with the filters, they get clogged and those kind of things, and you need to have special connections and things like that. But all over pulmonary vasodilators, you don't have enough data to support mortality benefit from it. And I don't think if you miss it or if you don't have it, it's going to be a big problem. ECMO option, that's for refractory hypoxemia. If your PO2 to FiO2 ratio less than 120 or less than 70, you have cardiopulmonary collapse, patient is not oxygenating well, you exhausted other other things with proning, neuromuscular blockade, patient continues to deteriorate. You don't have contraindications like GI bleed or limited survival or expected survival because of other pathologies. Then you might need to consider it if you have resources. The thing that's not listed here in my list, which is end of life issues. You need to address end of life issues with all of your patients from the time they hit the door, even if they are with moderate category COVID-19 presentation with just a few liters of oxygen by nasal cannula. You need to address the code status, end of life issues. We know from statistics that this illness can be complicated by hospitalization in about 20% of the patients. And from 100 patients infected, 20 might get admitted to the hospital. And from those people who get admitted to the hospital, statistics are different. You're talking about 15 to 25 or even 30% of those patients who get admitted might end on in the ICU. And the patients who end in the ICU, about 75% of them end on life support, on the mechanical ventilation. And when they end on mechanical ventilation, their mortality rate can be catastrophic. You are talking about up to 75% mortality rate for people who end on life support. It's a serious deal, and always address the end of life issues. Talk to patients' wishes about life support, the CPR, those kind of things. And you need to be so careful about making the decision on intubation. You need to address your patient's wishes before you make that big decision. COVID-19, special things, PPE, protective equipment, infection control precautions, that's number one. So essentially, COVID-19 management on mechanical ventilation, it's ARDS management, supportive measures, like any other patient. Add to that the PPE, infection control, that is the top number one thing for COVID-19 patients. Using antibiotics, initially you can cover patients with antibiotics empirically based on the risk factors for resistant infections, for community acquired or resistant pneumonia. But you do the cultures, the usual come back negative, you can discontinue or wean off the antibiotic coverage based on the culture results. DVT prophylaxis, a big topic here, but generally speaking, DVT prophylaxis, we give it to all hospitalized patients with COVID-19 patients, unless you have a clear contraindication. Low platelets, the patient is bleeding, those kind of things. Unless you have a contraindication, you go ahead and give the prophylactic dose of Lovenox or enoxaparin or the equivalent. We have some data to suggest giving the full dose of Lovenox or full anticoagulation for the patients based on the D-dimer. Some of the protocols suggest that you start the high intensity prophylactic dose for the moderate risk patients. And the moderate risk patients are those patients where you don't have the definite evidence of thromboembolic disease, but you have D-dimer more than 2000. So some of the protocols say to start the high intensity prophylactic dose, which is equivalent to 0.5 milligram Q12 hours of enoxaparin. For the people who have a clear evidence of thromboembolic disease, of course, like any other patient, you give the full dose. You have some signs alarming signs. I'm sure some of you guys went through some cases where you try to put a central line in, and once you get the flush aspirated from the vein, the blood in the syringe immediately clots, and even sometimes you have difficulty squirting the blood out from the syringe. That patient is hypercoagulable, or the patient is going through dialysis and you have the circuit or dialysis not able to keep going because of the lines being clogged in the process of dialysis. So you know the patient is hypercoagulable. Those patients without the evidence of or the definite evidence of thromboembolic disease by imaging, you can go ahead and give them the full dose of blood thinners, heparin or enoxaparin, or the equivalent. NSAIDs, some talk about using NSAIDs that they might be harmful to patients. If needed, you know, after you use the ice packs or those kind of things, and you need something to get your temperature under control, acetaminophen is maybe the medicine to go for. The next point is avoid nebulizers, and that comes under the umbrella of spreading the infection or the contagiousness of this virus. Try to avoid any intervention that would spread the infection. One of them is doing the nebulizer. If the patient has a clear indication for a breathing treatment, try to use the metered-dose inhaler through the circuit with closed circuit. If the patient is not intubated, you can still use patients. Patient can bring their own inhalers and they can use it in the hospital. Again, limit aerosol producing interventions like bronchoscopy. We have ongoing clinical trials on specific antiviral treatment. Dexamethasone, we addressed that. Remdesivir, the study on remdesivir showed like sooner recovery with remdesivir. We consider remdesivir early on is more beneficial than late in the course of infection. And because of unavailability of this medication, our system has like a strict sort of criteria to use it. If they present late after 10 days, we don't give it to those patients. If they have GFR less than 30, or if they have elevated liver enzymes more than 5 times the upper limit of normal, we don't give it to the patients. So you can still do it through clinical trial if the patient meets the criteria for remdesivir. Convalescent plasma, it's the plasma that we get from recovering patients from COVID-19. Can be helpful, especially in early stages, not too late. So it might give you some benefit, but still investigational. We don't have the clear-cut benefit proven yet. We have the MyClinic trial that we enroll our patients through. And we are hoping that convalescent plasma can be helpful, especially if we give it early on in the course of infection. All right, we come finally here to the weaning from mechanical ventilation. The criteria, of course, that the underlying pathology for which the patient was intubated is getting better. So that's essential. And the patient is following commands, can protect the airways, secretions under control. You have the FiO2 less than 50% and the PEEP equal or less than 10. Patient is hemodynamically stable. That translates into maybe if the patient on a pressor and he's on norepinephrine, for example, 10 or less, if they require norepinephrine, 10 or less can be considered for weaning. The patient does well on the spontaneous awakening trial, the SAT, and the SBT, spontaneous breathing trial. Now, the spontaneous awakening trial, the SAT, it's essentially a daily temporal cessation of sedation to achieve a RASS of 0. You see the Richmond agitation sedation scale, the RASS scale. I brought this table so you guys can see what it means, like the RASS of 0. Patient is alert and calm. He's not combative, he's not drowsy, he can follow commands, he is cooperative. And the patient is in the supine position, he is not prone of paralysis, hemodynamically stable, oxygenation is good, and the oxygen requirements not more than 50 and the PEEP 10 or less, and the last check on your plateau pressure less than 30. So those patients, if they do well on the awakening trial, we let them breathe on their own through what's called the spontaneous breathing trial, the SBT. Now, the SBT consists of a pressure support ventilation. We give a pressure support of 5 on top of a PEEP of 5 for regularly. That's for the patients before COVID-19. We used to let them breathe spontaneously on the CPAP with pressure support for 30 to 120 minutes. Now, this is a question mark here with COVID-19. Some authorities suggest that we let patients do the SBT for longer than 2 hours. Some of them suggest like 2 to 4 hours. Is that required? Is that going to be more efficient to rule out the shaky or uncertain cases? Or is this going to be helpful to improve the outcomes? We are not really sure. So what I would say, if you are doing the SBT, do it for 2 hours. Do 2 hours, which is like great. TPs, we use it for SBT, but it's not recommended in COVID-19 because of the loss of continuity. If the patient becomes in distress, increased respiratory rate, hypoxemic, hemodynamic instability, we discontinue the SBT. In the SBT, we calculate the rapid shallow breathing index, and if it's more than 105, then the patient is a failure. He cannot, get off life support. So the rapid shallow breathing index is a number. Essentially, we calculate it by getting the respiratory rate in over tidal volume in liters. If you have this number less than 105, your chance of success to get off life support is 80%. If your number is more than 105, your chance of failure more than like 95%. So it's a good indicator of success or failure with mechanical ventilation when you try to wean the patient off the breathing machine. So if the patient does well with the awakening trial and the breathing trial and he keeps doing well, it's time to extubate your patients. And again, when you do the extubation, make sure that your patient is covered. You deflate the cuff, put your machine on standby, or even shut off the ventilator. So when you deflate the cuff, you are not spreading the infection around. So again, focus on the protective equipment and be vigilant to the potential to spread the infection around. Do the extubation and monitor your patient for any deterioration. Causes for weaning from the ventilator, it's variable. Respiratory factors and pneumonia, inflammation, bronchospasm, or cardiac, pulmonary edema, cardiac dysfunction, or arrhythmia. Neuromuscular factors or delirium, sedation medications, and also metabolic causes like malnutrition, electrolyte disturbances, hypophosphatemia, one of them. So I will wrap off here and open chances for questions here.
شكرا دكتور محمود على المحاضرة والمعلومات القيمة. طبعا الهدف كان من هاي المحاضرة إنه بعض الأطباء الغير ما عندهم اكسبيرينس وخبرة في التعامل مع الميكانيكال فنتيليشن نفيدهم، وهذا هو سلسلة المحاضرات اللي راح نعطيها. أي شخص عنده سؤال بيستطيع إنه يكتب السؤال من خلال شاشة الدردشة أو الشات الموجودة على اليمين. كان في هناك سؤال من أحد الأطباء عن when do you use the prone position and the ECMO. يبدو أنك أجبته خلال المحاضرة. بعرف إذا بتحب تعطي تعليق بسيط كمان مرة عليه.
نعم، بالنسبة the proning position, we use it, or the indication for proning position, if you have your FiO2 to PO2 ratio less than 120, 150, FiO2 more than 60%, and PEEP more than 15. Those are like the indications by numbers, and you need to make sure you don't have contraindications. Patient has like abdominal surgery or trauma, flail chest, or hemodynamic instability. You need to rule out those contraindications. And the other important thing, make sure that your team is comfortable doing the proning position. So that is the proning part. When to stop doing it? Again, we do the proning for 12 to 16 hours. and we then flip the patient to the supine position for 12 hours. Then we flip over, we change positions. The time we stop is the time when we lose that indication. Roughly speaking, if I have to less than 60%, PEEP less than 10, the ratio is more than 150. بالنسبة للإكمو number one, make sure your patient is a good candidate for ECMO, number one. Number two, by numbers, if you have your ratio PaO2 to FiO2 ratio less than like 120 or like 70 is like very clear, for 120, and you exhausted your resources, you tried the proning, muscle paralysis, you did recruitment, you did everything you can to help oxygenate the patient, but he keeps getting worse. He is young, he has no comorbidities, he expected to live based on his comorbidities more than 6 months. And very important, you have the resources. You have the resources, in other words, you have like access to ECMO center. You can consider it, and in the process of doing the ECMO, if you don't have it, you keep in mind the process of transfer to higher level of care, and you need also to keep in mind the risk of spreading the virus. If you don't have the resources, if you don't have like a center where they feel comfortable taking care of ECMO patients, then you have tried. You have tried, and you just do your best with what you have and try to address code status with your patient's family.
دكتور محمود، في سؤال عن البلاتو بريشر، هل ممكن تفسر كمان مرة عن البلاتو بريشر وكيف يتم قياسه الفيجر؟
نعم. شوف، بالنسبة للبلاتو بريشر is the pressure in the circuit when you put the patient in inspiratory pose. In other words, في الماشين بيكون كبسة اسمها inspiratory hold. شو هاي الانسبيراتوري هولد بتعمل؟ لما تكبسها for 30 seconds الماشين بتخلي المريض ياخذ inhalation with the volume fixed on the machine, and then holds the breath for 30 seconds or for the time you need to hold it for, but usually you need to hold it for 30 seconds. هسه لما الامور تستوي في اخر 30 seconds, you get a pressure reading. You can look at the ventilator. If you can't do it, you can ask the RT. Most of the RTs can do that, and it's a simple thing. You can get the reading of the plateau pressure. That's what the plateau pressure is. هذا البلاتو pressure the meaning of it, they found if it's running more than 30, you have high risk of problems. High risk of problems in the form of barotrauma or ventilator associated lung injuries and those kind of things. So that's why they try to drive it below 30. Now the plateau pressure is part of what we call compliance equation. Now compliance means how much of a change in pressure for a given change, or how much of a change in volume for a given change in pressure. For a good compliant lung, you have normal lung, you have a compliance of 200 ml per centimeter water. إذا بتغير the pressure by 1 centimeter water, you have a change in the volume by 200 ml. فعندنا static compliance لما we close the circuit at the end of inhalation. We based on the definition like change in the volume by change in the pressure. For this patient on volume control mode, بنحسب the change in volume is the tidal volume. The change in pressure is the plateau pressure minus the PEEP. That gives you the compliance. So it's essentially part of the equation of the compliance. If the patient's compliance is low, you need to be careful. هذا طبعا part of the pathophysiology of ARDS. You have to be careful not to push it hard to reduce the effect of barotrauma and biotrauma related to an overstretch or you know, due to the effect of high pressures in the circuit. بعرفش إذا كان هذا كثير helpful بس إنه هي essentially if you want the number you can do the inspiratory hold and talk to your RT. He can show you exactly where the number is and how to do it. It's very simple. You don't have to wait or make you learn it once and you learn it for the rest of your life. But make sure that the patient is passive and cooperative with the machine and will sedate it when you do it.
شكرا دكتور محمود. إذا في حدا عنده أي سؤال تفضل واكتبه واحنا بنحكي للدكتور محمود. بس حبيت انوه ان طبيعه المحاضرات اللي احنا بنعطيها عن الكوفيد 19 احنا على تواصل في الباما مع وزاره الصحه مع زملائنا في فلسطين اللي بيعالجوا مرضى الكوفيد 19 وبنستفسر دائما منهم شو طبيعه المواد التعليميه اللي بحاجه لها وبناء على ذلك احنا بنختار طبيعه المحاضرات. الشغله الثانيه برضه في عندنا فرع التمريض في الرابطه الطبيه الفلسطينيه الامريكيه باما نيرس ان شاء الله راح تعمل سلسله برضه محاضرات شبيهه راح تكون موجهه للتمريض اللي بيعتنوا في مرضى الكوفيد 19 سواء كانوا على الميكانيكال فنتيليشن او لا. ان شاء الله المحاضره هاي بعض الاشخاص بيسالوا عن السلايدز. المحاضره هاي راح مسجلينها وراح يتم عرضها ان شاء الله ومشاركه الفيديو معكم حتى تكون الاستفاده عامه ان شاء الله. اذا ما في حدا اي سؤال حاليا بحب اشكر الدكتور محمود عمارنة على المحاضره القيمه وبشكركم جميعا على حضوركم وبشكركم على ما تقومون به في فلسطين من خدمه صحيه للمرضى على الرغم من الامكانيات المحدوده هناك. ان شاء الله موعدنا غدا في نفس الوقت الساعه 9 مساء بتوقيت القدس الشريف مع الدكتور مهند ابو عمر ومحاضره اخرى ان شاء الله. وشكرا جزيلا لكم وتصبحون على خير. دكتور محمود شكرا جزيلا.
شكرا يا دكتور يوسف وجزاكم الله خير وبارك في اعمالكم ان شاء الله.
شكرا جزيلا.